Good morning, everyone, and welcome to our webinar, From Helicopter to Hospital, How Ambient AI is Improving Emergency Care. I'm Greg Odland, co-founder and CEO of Playback Health. Today, we have the distinct privilege of hearing from two incredible leaders who are at the forefront of transforming emergency medicine, Dr. Payal Sud and Kolby Kolbet. Dr. Sud is the Associate Chair of Emergency Medicine at North Shore University Hospital and Chief of Geriatric Emergency Medicine at Northwell Health, headquartered here in New York. She is a tireless advocate for patient well-being, particularly in the critical environment of the emergency room. Her work focuses on ensuring comprehensive and compassionate care, especially for our most vulnerable patients. Joining her is Kolby Kolbet, the Chief Innovation Officer at LifeLink 3. Prior to CIO, Kolby served as Chief Clinical Officer and is a registered flight nurse. Kolby leads the charge in bringing cutting-edge advancements to air medical services, providing critical, often life-saving transport for patients in their most urgent moments. Both Dr. Sud and Kolby are pioneers in leveraging ambient AI technology to enhance patient care and support our frontline heroes. In emergency medicine, every second counts, and the journey from a clinical incident to definitive care is fraught with challenges. Seamless communication and accurate documentation are paramount, yet often constrained by time and high-pressure situations. Everyone on this webinar can sign up for a 14-day free trial on Playback Pro, the same ambient prescribed solution used by our panelists today. Liz will add the link in the chat. Dr. Sud, Kolby, thank you so much for taking time to share your invaluable insights and experiences on how ambient AI is making a tangible difference in the demanding world of emergency medicine. Welcome.
Thank you so much. So happy to be here.
I'm going to jump right into the questions. We have a half hour today, so we'll try to get through and we'll leave some time for our audience to ask questions. First question, what are some of the biggest pain points you're seeing in emergency medicine today, both in the ED and in EMS settings? Dr. Sud, would you like to address that first?
Sure, absolutely. With increasing patient volumes, more and more patients coming to the emergency department, some of them staying longer in the hospital, we're getting a lot of ED overcrowding, and this is a national problem. We have a lot of patients, waiting for treatment, waiting for beds to open up upstairs in the emergency department. And having so many patients there for the ED providers to take care of means there's just that much documentation to do. And all of that is leading to a lot of physician and provider burnout. And this is a major problem. People are passionate about the care they provide, but having the increased volume and the increased documentation needs definitely adds to burnout.
Kolby, how about in your world? How do you see it?
Yeah, very similar to Dr. Sud. The charting requirements expand beyond just the emergency patient care record. And there's things that we gather for compliance issues and legal issues and billing issues and quality, and we just continue to pile on more burden, administrative burden onto our staff because we want to improve quality. And so the charting has not changed for the patient condition, but what we're gathering data for has added to that. And on top of that, our staff at each base location will see 1 to 2 transports per day or per shift. And so their time spent with the patient is not that long compared to being in a hospital for 12 hours. But someone that spends an hour and a half with a patient can spend 2.5 hours documenting. And, not that that's taken away from patient care, but it's unnecessary, working not at the top of their license and not doing the things that they most enjoy, and working on projects like quality and research and things like that during their downtime.
Thank you so much. How did each of your organizations first come to consider ambient AI as a solution? And what problems were you trying to solve? Kolby, when you and I first met, we were talking about a lot of different ways where EMS is, it's where the patient journey starts. And so we've talked through this quite a bit. How did you come to consider ambient AI?
Yeah, I've been really digging into generative AI for about 3 years, and I participated in many seminars and taken many courses and certifications in the world of AI, and I just continuously saw the use of ambient scribes and kind of had the thought like, well, this would work just like physicians would dictate in the emergency department. Why can't it just listen to everything that we do? And then I started to learn that this was starting to begin in certain areas where there was more controlled settings, like primary care or the operating room. And I was intrigued by it and thought this would work if we can if it can hear through the noise. And we have a very austere environment, I'll say, and we're transitioning in and out of a helicopter or an airplane into a noisy car accident scene where there's generators running or hydraulic tools being operated and sirens and just lots of commotion. And then we're going back into the aircraft and then back out of the aircraft into an ambulance or into a hospital. And we needed a low friction mode, to be able to listen. And that was really the ambient piece was no longer the burden or the thing to overcome. That was reality. And now it was just, after I met Playback as a partner, I just learned that there's so much potential outside of just capturing information for the purposes of documentation, and having to copy and paste something, that I just learned that there's more integrations possible and needed, and the sky's the limit.
Dr. Sud, when we think about emergency medicine and the work that you all do, and really no one day is similar, and you've got to be prepared for all situations and all types of patients. The idea of having artificial intelligence and recording and stuff like that, like how did you come to consider ambient AI as a solution for some of the problems that you were trying to solve?
Sure. So similar to what Kolby mentioned, I think in the past we were more familiar with ambient AI being used in more controlled settings. And so when one of our partners who was aware of Playback Health being used in one of our sister hospitals in Northwell, it's a large healthcare system. So one of our sister hospitals was using it on the inpatient side and in the OR setting. He presented it to us as ED leadership, saying, hey, what do you think about trying this in the emergency department? And at first we were a little wary. Well, like, really, in the ED? Because listen, you guys know the emergency department, it's chaos. It's a controlled chaos, but it's chaos, none the same. Similar to Kolby, there's a lot of noises going on in the background, and there's a lot of conversations. We were worried, is this going to really hone in on the patient in front of us, or is it going to pick up a patient that's outside the room or next to us in the hallway? So there were all these concerns, but I must say, I am very impressed how all those issues that we had didn't actually pan out in reality. In reality, when we're seeing sometimes, like some of our providers in triage will see 40, 50 patients on shift, and 40, 50 patients means 40, 50 charts to document in, right? And so if you're taking the time to document after every patient, or worse, at the end of your shift when you need to be home with your kids, then that's really, time taken away from your own personal wellness. And again, that's going back to the burnout that we talked about. So instead, having this ambient AI available to us while we're seeing those patients and, still providing patient care and not worrying about jotting down specific details, but instead we can actually focus on the patient in front of us. I mean, that's why we went into medicine, right? For that human connection. And so we can actually now focus on providing that human connection while Playback Pro can do the part that's the least desirable for us, and it's doing the documentation for us. So we decided to pilot it at our site at North Shore, got positive feedback, really great positive feedback. And since then, we've actually taken it to our emergency medicine service line to make this, popularize this amongst the other emergency departments as well.
Perfect. Liz, I see we have a question from the audience. Do you want to throw that one in there?
Sure. Thank you, Greg. And so we've got our first audience question of the day, and this is, can you walk us through a real scenario where Playback Pro changed the outcome or at least made the process smoother for patients or providers?
Dr. Sud, do you want to take that one?
Sure. So actually building upon what I said earlier, where when we are a provider in triage, which is one of the shifts that we do, where we're kind of going through patient after patient, starting the workup, sometimes in the waiting room because there just isn't any space in the back, similar to what we talked about earlier, we're seeing multiple patients. And in the past, prior to Playback Health, there would be times I would remember where I would spend a 12-hour shift seeing about, say, 50 patients. And then after that, spend another 3 hours in the hospital to make sure I'm caught up on all the charting and, kind of dotting my I's and crossing my T's, because at the end of the day, medical documentation, it's, even though it's not directly providing patient care hands-on, it is so crucial to communicate to the next provider that's going to be able to take care of the patient. That's the language that we're using. When a patient, and if any of you guys have been in the hospital or had a loved one in the hospital, we know it can be overwhelming because there's so many providers involved, so much going on. And one thing that you always worry as a patient, as a caregiver, is everybody on the same page? Does my doctor that I'm seeing today, who I've never seen before, do they know what happened yesterday? Are they communicating? And the communication, part of that communication relies so heavily on accurate and timely documentation, because of which I would stay back 3 hours after my shift at times at the end of a busy shift to make sure all my documentation is complete. And when I had a similar shift post Playback Pro, that wasn't happening because I was able to get the documentation done simultaneously in real time while I'm providing care to these multiple patients.
Dr. Sudi, you brought up that, when we've all been in these situations. I was actually in a situation last week where my father-in-law was in the hospital, and Playback Pro was used to capture those communications, and a patient summary was provided to my father-in-law's wife and to my wife. And the beauty of that is that everybody feels like they were heard, and nobody had to worry about trying to remember or type or all of the stress that's involved in having to hear, understand, and communicate care instructions. It was covered in the Playback Pro, and it really, from a patient perspective, it was so nice to be able to see that and know that that you heard it correctly and that you had the notifications to follow. Kolby, from your perspective, how would you think about this question? A real life scenario. I know you guys have a number of these. I'd love to hear from your perspective.
Yeah, well, I think the most interesting part is during the testing phase and simulation, and we had to gain trust from our staff, and they didn't want Big Brother listening, and weren't sure if it was us spying on the staff or not. So we did include the use of it with several iterations of our human patient simulation situations, and one of them was a GI bleed, and we just let it run, and then at the end we would show them the summary as well as the transcript to basically see how accurate it was, and in the summary how it stripped out the extraneous things that were non-pertinent, like the side chatter and the laughter and the talking while they're transitioning from the simulation room to the aircraft. And since the patient was a GI bleed, you always worry about cardiac involvement, right? And doing a 12 lead and making sure that the coronaries aren't, underperfused. And when we were done with the simulation and we provided them with the summary and the transcript, they saw that it captured that this patient had several episodes of chest pain the night previous and in the morning, but never heard it. And I thought that was an interesting thing because they're like, well, how do we know it happened? I said, you can play it back. You can listen to it if you want to, right? And clearly, if it recorded it in, and caught it in the transcript and the summary, it was said. In especially if you can go back and actually listen to the audio. So that was really an eye opener for me. And I think the other thing that the real life scenario that hasn't happened yet, but it's what we're actively working on, is somewhat to what Dr. Sud said, timeliness of our documentation. When we transition a patient into the emergency department or to the ICU, our documentation is not ready for the hospital to see. And that's for multiple reasons, because we're on a different charting platform, all EMSs from hospitals, and it takes time to document a chart on a very critical patient. And there's it's whether or not the hospital uses that document or just goes into the medical record somewhere. There's so much valuable information on there that just does not get utilized appropriately because there's no easy means of getting it right into Epic or Cerner or Meditech, whatever it may be. And if we captured all this audio en route to the hospital, it'd be the equivalent of what we call a short sheet, where all the medications, the doses, the times, and the routes, and the key elements that trauma teams care about. Was there any documented blood pressure below 90 during your encounter? That type of thing. A description of the scene, whatever could be captured there and be transmitted, right to the emergency department or the receiving team. So that's what we're working on. And then obviously, in our world, we're working on a full-blown integration with a charting platform, so that the information can go right into the correct fields and then be more usefully captured and recognized and transferred via the HIE. So
terrific. I know that, like, when I'm using AI and I know that it's listening to me, I think differently about what I say or how I communicate it to others. What has your experience been at the point of care? Dr. Sud, maybe you want to think about this. Is like, does it make you think differently knowing that AI is listening, and obviously it can't hear your thoughts, it can only hear what you say? Like, how do you think about that?
Yeah, it's interesting. I think especially when we first started using it, we were all a little bit more aware, right, that it's listening. But in some ways, like in a good way, you're more mindful of what you say, how you come across to the patient. Over time, though, because it is so subtle, you don't notice it. You do get used to it, and which is good because you don't want it to completely take away the natural, doctor-patient interaction that is normally going to ensue.
Yeah.
So now that we've gotten used to it, honestly, we don't really, I mean, at least I don't really think about it that much. And it's just, kind of part of the tools that we're utilizing as we're taking care of patients.
Kolby, you and I have talked about this now. You can add to your list of certifications, prompt engineer, I guess. When you think about it in high intensity helicopter interactions, like, how does the flight team think about being recorded, and does that change? In the same question to you, does it change the way that they do what they do?
I don't think that the folks that are using it, it's more of a challenge to see how much more they can capture. So the benefit of that is obviously the more you talk and look silly, the better your documentation is going to be. And, so we've incorporated timestamps now. And so one of the neat things is if they just say, hey, they can start an IV without saying anything, but to capture the elements that are required for the NEMSIS database, which is the National EMS Information System, if you say I inserted an 18 gauge IV in the right antecubital space, and it was successful with that one attempt, and I have the normal saline run at TKO, and complications were none, and patient improved or patient remained the same. And so those are all the elements you need to document for one intervention. And I might not say them all, but the more I say each time, there's that much less documentation. Same thing for capturing quality and patient safety items, like med check on a high risk medication, such as given a bolus of heparin or given TN case, or something that can have ill effects on the patient, requires that double check, just like blood does. And you capture that element on there. Doesn't need to go in the chart necessarily, but it's there as that defensive documentation or that proof that we're actually following best practices and patient safety standards. So I think the key element is we're all going back to our original training or education, and we're back in front of that mannequin, and we're walking through our head to toe assessment and saying everything out loud. And we did that to prove our competency, and now we're doing it to make the documentation come to life.
Yeah. It's amazing to kind of think about all the different ways where at least in the helicopter, you have a number of people, some are clinical, some are flights, and to see how different people have a role in communicating care, and how much information is actually lost. I mean, you all know it because you're in the helicopter, but when you think about the patient journey and what's important when you drop off the patient at the emergency medicine room that Dr. Sud might serve, having those details may mean something very important at the point of care. Dr. Sud, do you think about it that way? Like when the patient arrives, normally you don't have a whole lot. It might be a Jane Doe or something of that nature, and you really don't have a lot of information. So I'm sure you're pretty starved for as much information as you can get on the incoming. Like how does ambient listening, and how do you think about that?
Yeah, 100%. I mean, a couple of things on that. Kolby, to your point that the EMS PCR is such an important piece of documentation that has such crucial information for us, but often depending on what agency it is and the lag time, we don't have access to it. And there's so many times I do a lot of quality reviews for cases. We see that how important what an important piece of the puzzle it is to see, well, what was the EMS report? What was, obtained out in the field? And if we have tools to make sure that communication is seamless, I think that would just make all of our lives so much easier. And most importantly, the patient's lives so much better. And, another thing that I think about is, so I often review what are called our kind of patient experience comments, or press gaming comments. And time and time again, no matter which ED I've worked at, there's one section that I feel in the emergency department we can always do better on, patients feel we could always do better on, and that is asking patients about what medications they take. That's something that often comes up. And specifically using ambient AI, I think it has been so helpful, not just for myself, but other docs that I've talked to who've been using it, where part of the problem is you go ask a patient what medication they're on, and especially if you're at a hospital like ours, where we get, we're the quaternary care center for Northwell Health. We get all of the transfers, we get all of the referrals. So these are very high acuity patients on multiple medications with multiple specialists, multiple names, dates, appointments, all of this information. There is no way you're going to be able to remember all of this information. And if you're just writing it down, you're not maintaining eye contact. But now with ambient AI, we're able to log all of these specific details, kind of those hard facts that can make their way into the node. And so you can spend more time talking about the subjective aspects of the care as well. So which has been extremely helpful.
Well, I think, as it pertains to geriatric care, care of older patients, that patient population, as we know, is getting is growing quickly. And the population of clinicians serving that population is not growing as quick. And so one of the things that comes up quite a bit is this idea of physician burnout. Dr. Sud, how has ambient AI impacted physician well-being and reduced administrative burden in your ED, specifically around things like burnout? And what I've observed in Northwell is very often sometimes the typing might be done by a nurse practitioner, or it might be done by a scribe, or it might be done by somebody else, but it always requires somebody else to come in the room, someone to hear it, someone to confirm it, and someone to type it. Like, how do you think about burnout and meeting that problem in the emergency room?
So, depending on which emergency department you practice in Northwell, you may not have a scribe, you may not have an NPP or a resident. Prior to North Shore, I was at Glen Cove, which is one of our smaller sites, and they're often, attending only solo one physician coverage shifts. And especially at a time like that, when you are the only person, there's a lot that you're doing. You're getting the information, you have your hands on the patient to do a procedure. You may not be actually having your hands free to write down all of the information. And at that time, we didn't have ambient AI. I wish I could go back in time and use it then, because it would have been so helpful to just have that extra set of ears for me. So, I can focus on just being the hands-on provider where all my information is still being captured.
Well, I know we're getting close to the end here, and I do want to leave a little extra time for some of these fun questions. There is a question from the audience. It's a great question. Liz, do you want to cite it?
Sure. So we've actually got two audience questions if we have time. One we've got in here refers back to something Kolby was saying about gaining trust with teams. It says, so interesting about gaining trust with teams, makes a ton of sense that is needed with ambient AI, would love to hear more about that process if there's time. So Kolby, I don't know if you want
Yeah.
to kick it off.
Well, one of the things that we're working on doing is obviously building policy around this and trying to determine what best serves our staff, whether they need the full transcript or just a summary that's provided to them at the end of their encounter. And I've been trying to build trust with them to in the summaries, not to have that extra burden. But if they feel that the summary would be inaccurate or is missing something or hallucinated and added something that they didn't feel was true, then we would resurrect the transcript for them on their behalf. But it was more out of we want to treat this like we do anything that's highly confidential and not have that where they feel it's available to just anyone to review everything that was in that transcript. Like, were they talking bad about our organization or our leadership and silly things like that they would actually worry about. And so treating this like, you need to make a formal request to access this and for what reason. And that would pertain to everybody in the organization, so we can maintain it for quality purposes only. And then that also allows us to, if there is a hallucination or a word there's a inaccurate medication name or something like that came across, we can give that feedback to Playback and they can update, the library, which has been fantastic. So not having that available for just anyone for access also adds to the trust. And it shows that we're only interested in what's in the summary. And if there's things that come across in the summary that we don't feel are necessary or appropriate, then we can also work with Playback on that. But treating it like it's inaccessible to everyone is, except for certain purposes, is how we're tackling that.
Terrific. Maybe now is the last question there, which is always a fun one to ask. Liz?
Yeah, I think we gotta end it at some point. Unfortunately, this has been really great hearing all of this from you both. But so our last question from the chat, it's an audience question. Imagine you have a crystal ball. Love that. How do you think AI will impact the future of emergency medicine and your roles, and the quality of patient care and provider life?
Dr. Sud, what does your crystal ball say?
Sure. Can I pick two things? Because there's
Sure.
there's two things that I wish we could do. And one, maybe we're almost there, but as I think one of you guys mentioned, when patients come into the emergency department, we don't have a lot of time to gather all the information, go through all of the charts, especially now, when they're online, there's a lot of information out there. So having like a generative AI that's able to summarize all of that in like 3 or 4 bullet points to tell us the most important thing, that this is what the patient's medical problems are, these are the medications, this is the most recent appointment that had the patient had this MRI that showed this. That would save so much time and allow us to act, really like hone in on our best educated guess as to what's happening with the patient at that time. That would be extremely helpful. The second thing that it's not exactly related to emergency medicine per se, but medicine overall, is kind of going back to where we started, where we were talking about hospital overcrowding and older adults and the population increasing more and more. We want to keep this population out of the hospital, right? We want to be able to provide them with access to care at home and in other places. And having some kind of like AI incorporation into remote monitoring and diagnostics for like a hospital at home, I think that would be the dream. I think that would be so wonderful, where we can provide the same care to our patients when they're comfortable at their home.
Yeah, this ties in very much to to the roadmap that we consider. Certainly pre-charting and having all the patient information before the patient shows up is really important. Some of that is structured information that comes directly from the EMR and can populate the note. Others are questions that can be asked of the patient to populate the note. And we've been using both of those applications in providing a more complete note. On the other side of that, Ambient AI, because it listens and hears everything and transcribes it, you're also able to do things like coding and billing. You're able to put in prescription orders. You're able to get insurance pre-approvals. The beauty of AI is that it allows you, from an agentic standpoint, which everybody is talking about and chasing right now, this ability to be able to do a lot with the transcription to further reduce administrative burdens on clinicians. So very much appreciate that crystal ball. Kolby, what does your crystal ball say?
I also have two, and The first one is probably the most obvious, is wearables for our clinicians, like, something like the Meta glasses or whatever that interprets our surroundings. None of our diagnostic equipment talks to, or our, therapy equipment. I talk about the ventilator, the cardiac monitor, invasive lines, ultrasound. Nothing currently ties that data all together and processes it. And, currently that's obviously due to processing capabilities. But if that could process that information in real time, along with what it's hearing us talk about the patient, to be able to help generate action plan, a care plan kind of item. But furthermore, when we're in the EMS setting, if the world where everyone had a wearable and it was basically capturing our digital twin, right? But if EMS was able to access it essentially, and it gave us the last 24 to 48 hours of symptoms or something that is contributing to this current illness or injury. I think that there's a lot of potential in that, because we're never going to get something that we said 10 years from now, because it's just going to be in our digital twin, and we're never going to be able to lie, and it's going to be a different world out there. So I think that's exciting, but I think the world is going to be so connected. But I think it's the consumer ambient AI, it will play into healthcare AI. That would be perfect.
Well, I see that we're at time. Dr. Sud, Kolby, thank you so much for giving your time. Like I could have this conversation for another 30 minutes. I really appreciate it. The reason that we started Playback is really this opportunity to be able to serve clinicians and help technology help you do your job better. And so if we've learned anything or taken anything away from this, I feel like we're well on that journey, and we're super happy to have both of you on board and serving this. So thank you so much for your time. Thank you so much for your service. Thank you, Liz, for putting all this together.
Thank you for having us.
Thank you. Appreciate it.
Thanks, everybody.